Good. Okay, guys. Yeah. So as we said, so this academy, EM Skills Academy, we're running the courses for the MRCEM, FRCEM exams, online and face-to-face. We also running some courses for the interview preparation, for the ACCS interview, and for the higher specialty training interview. We've done a few of them. And thankfully, most of our candidates gets like their first preference on their training posts. The other thing, we as well give a bit of advice if someone need to pursue a career in emergency medicine. So we've got what we call a free career consultation, which you can book through our website. And then one of our consultant will give you a slot for 20 minutes to have a chat with you about your personal circumstances. If you need any advice with your training, with your future career in emergency medicine, if you're doing a Caesar, or if you are in actual training and you think about subspecialty or so. So we've got a few of CCT doctors and dual specialty doctors as well on our faculty team. So these are the courses we're doing, as I said, MRChem OSCE course online and face-to-face, FRChem online and face-to-face. And we are going to India as well on June, is it, Mehdi, to deliver a course, 3 days. The interview prep course and then free career consultation, which you can book from here on our website, emskillsacademy.com. So we got an extensive faculty. There's a very long list as well. Few consultants are missed here, and senior consultant. You can find all the information on our website, our team section. So,
We got
Dr. Yeah,
we got George here. George, do you want to do your introduction by yourself?
yeah,
Hi,
absolutely.
can you hear me? Just
Yeah.
checking if
Yeah.
you hear me. Hi, so
Hi,
I'm
George. You okay?
Georgina Robertson. Hiya. I'm a consultant at ELHT and clinical director. I've been a consultant since 2010, so 15 years, and did my training in the Northwest, and I did dual training with intensive care medicine as well as emergency medicine. Nice to meet you.
Thank you, George.
Yeah, good. And you want to introduce yourself, Mehdi, as well?
Yeah, my name is Dr. Mehdi. I'm consultant in ELST from last 4 years, and I'm deputy clinical director working alongside with Georgina, and I'm ex-examiner of the Royal College. So I recently resigned from examiner because I started working with Khalifa in this project, so we cannot basically be examiners and run this. So huge experience of setting up papers for Royal College, whether these are SBA papers or OSCE. So we know in and out how we basically set up OSCE stations. And in addition to that, I'm UCLan lecturer, so I teach in UCLan University once a week. Thank you.
Great, yeah. And myself is Khalid Khalifa and was any consultant in Manchester University Foundation Trust within Shaw Hospital. And I have the honor to work with Dr. George. She supported me during my training as well before I became a consultant a few years ago. And as I said, like founder of EM Skills Academy, which is now established to help all the emergency medicine doctor in their career. So we still got more senior consultant as well, Dr. Hamza Zafar, who's a senior clinical lecturer, King's College London, consultant in emergency medicine, and the Caesar lead there. Dr. Shokbir Buller, who's the TBD for the examination on the Northwest and was an ex-examiner as well, consultant at Blackburn Hospital. Dr. Mo Abu Omar, who's a dual specialty senior trainee in the Northwest. So we bring you guys an extensive experience, very senior faculty to help you to go through your exams and emergency medicine career. our future courses, upcoming courses, we've got the FRChem OSCE course on the 29th of April for the next night, which is around fully booked now. We'll only get very few slots available. We've got two courses for you guys, MRChem OSCE, one online and one face-to-face. So the online course will be on the 3rd and 4th of May, and the face-to-face 24th to 25th of May on Burnley General Hospital. And then there's the one in Hyderabad as well from 8th to 10th of July, just is it June? Yeah, just before the exam. So, any questions so far about our academy, or anyone have any question? I see someone is writing something in the chat. Let me have a look. I am listening while on duty. Okay. Able to talk while listening. I'm senior doctor in Sri Lanka, special in RChem. Waiting for OSCE. Okay. Yeah, okay, perfect. Yeah, if you need any help, just get in touch. We've got our Telegram group, we've got WhatsApp group, we've got Facebook. If you need any help, just give us a shout. We more than happy to help. Great, fine. So let's jump on to the exam. And we'll give the mic to Dr. Mehdi to give us a bit of orientation about what is MRChem OSCE exam looks like. Yeah, Mehdi.
Thank you, Khalifa. Welcome everyone to EM Skill Academy. So today, basically, I will give you a summary of what exam MRCM is like and how, as an examiner, we, assess you during the OSCE stations. And then how do we normally mark so that you will have an idea how should you perform, how should you prepare, and how well you should be preparing different domains. First thing is OSCE, it's a practical clinical examination, isn't it? So normally we have 16 stations and 2 rest station. Total time in the exam is 2 hours 42 minutes. That is 16 stations plus 8 minutes. 1 minute is normally preparation. I'll tell you in few minutes what you need to do in that minute. And these exams are normally held in London and Malaysia, Chennai, Hyderabad, and Kochi in India. And, basically, these are all clinical and communication skills. We will go in detail in next few slides. Next slide, please. Right. So, few years ago, we were doing a checklist-based assessment. That's gone now. Now we do a domain-based marking. So what does that mean? So if you remember, do you all have 125 ASCII book? I think you all should have. You still see there is a tick box. So if you have asked this question, it's tick. If you asked this thing, it's tick. If you have washed your hands, it's tick. That used to be exam. So what we found in that tick box system is, we had a pendant who it was a patient with chest trauma. Patient had pneumothorax, okay, tension pneumothorax, sorry. So as per the tick box, he has asked all the questions. So he was scoring about 88% as per the tick box. But when he was shown the X-ray of tension pneumothorax, he couldn't recognize it's tension pneumothorax. Then we thought, this is not going to work. This is not the best way to examine. So let us forget about tick box system. Let's introduce domain-based system. Domain-based system was before that introduced by GM for labs. Before us, they introduced it. So domain-based, basically what it is, examiner sits in the room. He doesn't write anything. So he will normally have an iPad. He will be looking at you as a clinician of your grade. For example, if it's MRCM at a registrar level, he will be looking at you. He has given you a case. He will be thinking whether you are okay to run the department at a registrar level, whether you are okay to treat safely that patient at registrar level. If it's FRCM, then definitely day one consultant. So although it is just purely his judgment, what he thinks about that station, but still there are some 7 domains he has to mark. He cannot mark you if you are good in communication, but your interpersonal skills are not good. So there are markings, but mainly it is his judgment. So basically, RKM OSCE examinations follow a domain-based system. So what we do is it's a style of assessment in which candidates will be assessed against series of domains. Next slide, please. Okay, so for MRCM, there are different domains and there are same domains we check in FRCM, but there are some additional 2 domains in FRCM. So what are the domains like? So one domain will be clinical reasoning and decision making. So you will be given a scenario. In that scenario, maybe 35% of the scenario is making a decision. For example, if you've taken history, you are done examination, you are not making a decision like differential diagnosis and management, you will not pass that station. So 35% or 30% will be in some scenarios like clinical reasoning, you have to give the reason if there are questions and you have to make the decision. Practical skills. So yeah, if it's a practical station, definitely you will have some communication and the practical. So none of the station will be only purely on one domain. It is normally 1 to 4 domain in each. So you will have some communication skills tested in that and some practical skills. Similarly, communication skills is one of the important, and I can say one of the main domain. Almost every station will have a bit of communication skills. I think every station, as an examiner, as an experience, every station has at least 20% of communication skills. Then teaching, if it's a teaching station, maybe 50% will be the only teaching marking in that station. Then history taking, information gathering, organization skills, and then clinical examination skills. These are the 7 domains we check in MRK OSCE. The next slide, please. FRCAM is same 7 domains, but there will be 2 additional. One is research and data management, and one is the leadership. These are the additional domains we check in FRCAM in addition to MRCAM 7 domains. So next, please. There should be one more before that. Okay, yeah, no, that's fine. So in each OSCE station, you will have 1 to 4 domains will be tested. For example, if it is a history taking station, say foreign travel, right? So foreign travel, so it is basically history taking, but so we will not be only marking you on the basis of history taking. It will have 3 domains in it. One will be how good you are in gathering the information. So it's like gathering information, how good you are in history taking, and how good is your communication. And there could be 4th domain as well. What is your decision about, I mean, your management skills or your uh, diagnosis. So basically, every station will have either 2, 3, or 4 subdomains. So for example, if you're taking a very, very good history, but your communication is not great, you're not going to pass it. So you have to make sure that your communication is good with the patient. You show empathy and sympathy in that, isn't it? And each domain will be weighted separately. For example, if it's a practical station, say it is suturing. If you have done a fantastic suturing, that means if in that domain for suturing, a practical skills, it is 60%, but other 40% or, for example, 20 for communication skill, com, uh, 20 for some interpersonal skills. If you are not scoring that, you will not score that. That means every domain will have separately weighted in each station. So you have to perform all the domains in each station very well to pass comfortably. And then in relation to overall importance within the station, candidates will be assessed by examiner who will form a judgment on the level of the competency they display in each domain and skill, ranging from well below the minimum level of competence to well above. I'll show you in the next. So basically, when we mark you like this. So we have in every domain, we have these 5 tabs. One is well below the minimum competencies. The second one is below minimum level of competencies. Third is minimum level of competency displayed, then above the minimum level and well above them. So we do not have a mark like 2, 3, 4. So it's not like that. Every OSCE station has a maximum of 10 marks, but that is hidden. That's not us to decide. So what we do is we click one of them. If you are doing amazingly well, you are very good candidate, we will say well above the level of competence. So then the iPad itself has a marking for that, maybe 9 out of 10, maybe 10. That automatically calculates overall numbers. So then what does well below minimum level mean? That means very poor level of knowledge and skill displayed. And what does below minimum level of competence? That means below minimum level of knowledge and skill. And minimum level means below minimum level of knowledge. And above is above minimum. So it's like that. So it depends upon that day how good you are doing in each domain. Then we click on these buttons on the iPad that automatically calculates your numbers. Next one. Again, the examiner, oh no, go back, go back. The examiner judgment of the candidate performance on each domain within the station will be converted into the numerical value. As I told, there are, numerical values underneath these, well below, well above, something like that. The numerical values of each domain will be calculated. So as I told you, each station normally is scoring 1 to 10. And then 16, there are 16 stations in MRCEM, OSCE, and the minimum score achievable in MRCEM is, maximum, sorry, is 106. So if 16 stations and 10 is the maximum each, so 160. So then it depends on each exam where we set that percentile. Next. Again, each exam day is different. It's separate day. Each exam is separate. So each station is separate, isn't it? So every time there's a separate pass mark and possible different stations. Again, different stations now. So there used to be, this is very important information you should remember. So in Royal College, we do a set of 10 days or 12 days exam. So do you think that every day the paper will be same? Yes or no? Yes, some are same papers, we same stations, we continue. Some we change, but be very, very mindful. So there's a trick we do normally. So first day, for example, if there's a ECG interpretation with patient coming with chest pain, first day probably we might keep STEMI. Second day we might keep, it will be same ECG station, but it could be unSTEMI. Third day, it could be unstable angina. Fourth day, it could be normal ECG. So do not go to the exam preoccupied. Be very mindful. There might be, oh, we had a last time, limping child. On day one, we kept Perthes disease. Then maybe people, they have friends, they told them, oh, it's a Perthes disease. And the next day, people came directly, oh, yeah, it is a Perthes. It was not, it was Sophie. So in that case, we have a tab on iPad that you think this candidate got an idea already. Somebody told him. So we red flag that candidate. So if 3 consecutive or 3 examiners red flag that they think he already knows the station, then it will be investigated. So be very mindful. So you have to be, even if you know the station, you should be very open. You should keep your eyes clearly open and think about the station, isn't it? So it could be same station, it could be different, but just keep your vision wide. Next, please.
Perfect. Yeah, I think we've done with this, Mahdi. And this, thanks so much for this your valuable insight about the exam. Yeah, so as Mehdi said, guys, it's a domain-based assessment, and there is 1 minute preparation before you enter. So it's a 16 station, isn't it? 1 minute preparation when you read the scenario and look to the pie chart, and then the pie chart you have to carefully understand what they want, what is the task from this pie chart, and what is the task from the instruction outside. So it's very valuable 1 minute preparation. So you know what is the domains you are going to do. Because if you said like this a patient have a shoulder pain, and please go and take a history. So, and history taking is a big chunk, like 70%. So it's purely a history taking. You may do a very, very brief examination, but if they done like on the pie chart, examination is 50%, communication is 25. So it is an examination. So it's the same station, but with a different pie chart. Make your mind change and your approach to the station it changes as well. Okay. So far,
Let-
anyone
I'll,
have any question to Mahdi?
yeah,
Yeah,
I'll add one more thing before the last question.
yeah,
About
absolutely.
this
Yeah.
1 minute, as Khalid said, this 1 minute basically decides your station. This 1 minute is very important. Do not bring your previous station's experience into this 1 minute, whether your previous station was bad or good. Just forget about that in that room. So, as Khalid said, so it's this 1 minute you have to basically read that station, and it takes just few seconds to read. Those normally are written 3-4 lines, not more than that. But you have to make a map there. Your brain should open. For example, if it's a chest pain, so you should think, okay, this is pie chart. It is mainly history, and there is some, if it's not a clinical, examination, then you have to think if it's chest pain, history taking. So, okay, what you have to think there, what could be the possible reason of this asking chest pain? So, abruptly, your mind should open looking for the cause of chest pain and what things you need to ask to the patient. So, very
Yeah.
important 1 minute.
It is very important, and the advice is to have a structured approach for every kind of station, like
Patient.
research station, trauma stations, history taking station, mental health history station. So it's a structured approach for all category. And then when you are in this 1 minute, have a look to the pie chart. What is the domains, and then just fit this to your structured approach. You'll tick all the boxes and you will pass clearly. Fine. Before we start, anyone have any questions? If you have any questions regarding the exam or what Mehdi just explained, just yeah, unmute yourself and ask, or just pop a message on the chat. And after the questions, we will do a mock station similar as we do in our online courses, and it will be the same as you will see on the exam. So any questions, guys? Fine, don't think there's any questions, but again, feel free just to write on the chat if you need anything. Good. So, anyone from the attendee want to be a candidate in this station? So he can do some practice, and then we can give him a feedback afterwards. You're having the exam shortly, guys. So do some practice. Don't be shy.
Hello, sir.
Hello, who's that?
Yeah, I'm Murtaza with you.
Mortaza. Okay. Do you want to be a
Yeah.
candidate, Mortaza, for this one?
Yeah, I will try.
Great. When your exam?
June.
Perfect. Okay, that's good. So, Mortaza, that's what we're doing now. The same as your exam. I'll give you. So I'll pop the instruction on the screen for the station. Give you 1 minute, full 1 minute. Okay, it's
Okay.
yours. Do your preparation. Then I'll say start. You will enter the station. You've got an actor with us, Dr. Abbas, and then it's full 8 minutes. Okay.
Okay, sir.
All right, let
That's
me put the timer on. Okay, ready, Murtaza?
Yes, sir. Case 132 is pregnant woman and the chain collision. She is reported to be the hypertensive at the scene and is with the growing pain. You are still attending with the trauma at midnight. Symptom of the patient. Blue decision making. Medical examination and skills. Okay.
You want to turn on your video?
Yeah, sorry. You can see me?
I can see you.
Yeah. So,
You
should I
can
start?
start now. Start.
Yeah. Hello, I am Dr. Mutsa, one of the registered today. I went to the AR room. May I know your ATLS provider? Your ATLS provider? Yes, staff nurse. And if she is telling yes, then I will tell them that we got. Hello. Hello.
Khalid, are you frozen?
Yeah, I'm not frozen. So Fakhra is a nurse.
Yeah.
He's muted. Sorry, mate. Let's stop. Let's stop here. You muted, Fakhr.
Can you hear me?
Yes, I can hear now.
Okay.
So you've got a bit of echo, Fakhr.
Yeah.
Should I start?
Yes, yes.
Yeah.
Yeah,
Hello.
great. So we'll start again. Sorry, mate, about this technical. Yeah. So let's start. Yeah.
Hello, I'm Dr. Mutsa, one of the AD registrar. May I know your level, please? Your ATLS provider?
Yes.
Yeah. Just we received a telephone call. There's a pregnant lady, 32 weeks, coming with the collision, in pedestrian collision, and we need to manage her. Can you manage the airway and breathing systems?
Yes. I will
And
help
also,
with that.
also we need to manage the IV trolley and all the medications if there is needed. Is the
Yes,
patient
I will.
arrived?
Yeah, Bishan arrived.
Yeah. Hello. Can we got any handover from the ambulance team?
32 weeks pregnant woman involved in RTC. No other information. She's in a lot of pain.
Okay. Hello. Hello. How are you? Can we immobilize the neck with the cervical collar for her, and we will keep the patient, take the patient in the resuscitation room. And hello. How are you? You are feeling. How you are feeling now?
Yeah, doctor, a lot of pain. I've a lot of pain. I struggle with breathing.
Okay. Okay. So I will start the airway. Airway is pattern for this patient. Sister, can we give some painkiller for this patient? And can we?
Yes.
She's
What
pregnant.
do you
And
need?
as she is pregnant, so we will give 1 gram IV paracetamol for her first.
Okay, 1 gram. Okay, I will go and collect.
We connect the IV cannulas for him and collect 2 bottles of blood. Also collect cross match for her during putting cannula.
Okay,
And
yeah, I will prepare for the cannula and the medication.
So I will examine the patient now. So airway, the patient is talking with me. So airway is pattern for this, and we will go for the breathing, and we will examine the chest and chest inspection. We will take permission that we are doing inspection for your chest, and there is all
There's a bit
the
of bruise on the right side of the chest.
bruise on the right side of the chest. I will do the auscultation of the chest, and in the I will
Reduced air entry on the right side.
reduce entry on the right side. So we will do percussion on the chest, and percussion we will on the right side, percussion note
Dull on the right side.
dull on right side, and percussion note on the left side is normal. So as patient is already in pain, and patient having use, so we will check for the trachea for this patient. With the position of the trachea is normal,
Central.
central trachea position. As patient is having a dullness on the right side of the chest, and there is a bruise on the right side of the chest, and percussion note is dull, and we will examine the whole right lung is dull in auscultation, or in the down
Yeah.
holes down.
All
So
that. Yeah.
we are suspecting that there is a hematoma inside the right side of the chest wall, but trachea is in position. But we need to do for her chest drain. So prepare for sister. Can we prepare for the chest drain for this patient? And
Okay.
we need some painkiller, local anesthesia also. We'll
Mm-hmm.
put the local anesthesia on the right side, on the fifth intercostal space, in the safe triangle above the sixth rib, and there
Okay.
we will put the local anesthesia and wait for 5 minutes to become that area numb. And in between we will examine the abdomen of the patient. Is abdomen is okay for the patient?
Yeah, abdomen standard global.
And also in the pelvis is okay for this patient?
Belt is stable.
Yeah. So as breathing circulation is how we have connected the monitor to the patient, whatever the blood pressure, whatever the pulse rate, and heart rate is raised, and saturation is 72%, BP is low. Please connect the patient to the oxygen, and we will connect the patient to IV fluids. And also we have sent for the cross match, and please
Patient.
inform the also we have collected blood gas for this patient.
Okay, so patient is connected to the oxygen and on the
Yeah.
cardiac monitor as well, and we have
Yeah.
taken the bloods and sent to the lab.
And also we want we have any O negative bloods for this patient.
So major hemolytic protocol has been activated.
Yeah, please activate measure, and we need 2 units of O negative bloods from this, and we will wait for the cross match for later on. So can we start IV fluid also for this patient?
Okay, what do you need?
We need normal saline for this patient.
How much?
Normal saline 30 drops per minute.
30?
Drops per minute.
30 drops per minute.
Yeah.
Okay.
And also if we got O negative blood, we will start 1 unit of O negative blood also for this patient. And we will call the gynae team also, as patient is 32 weeks pregnancy. So we need help from the gynae to look out for the baby's condition in the abdomen.
Okay,
And
so I will first leave to the gynecology as well.
yeah, and also sister, can we expose the patient? Is there any bleeding in the vaginal side or anything? We need to examine that also.
Okay.
So the there is patient is ready for the chest tube. Chest tubes are ready to insert.
Fine, you've done the chest tube.
The chest tube is done. So we'll check that the chest tube is okay or not. The air bubble is coming or not. Then we will again
Bubbling, yeah.
yeah.
Working fine.
Then we will take auscultation of the chest. The air entry is on the right side.
Bit better. It's a bit better.
Yeah. So it is better. So our chest tube is in position. We'll keep the chest tube in position with water seal drainage.
Okay.
And also we will now check about the patient. How you are feeling now? Is there any pain now, or you are feeling well?
She's still in a lot of pain.
Still you are in pain?
Yes.
So sister, can we prepare morphine for this patient? We need to give 5 mg morphine IV for this patient for pain management.
Yeah, I'm going to grab it.
Yeah. And how is circulation? What about the blood pressure? Any changes in the blood pressure? Is a monitor, and there
The
is a
same.
heart rate is the same. So heart rate is more than 110. It indicates that there is a internal hemorrhage is there. And in the water cell drainage, we are seeing any blood is coming in the water cell drainage.
Yeah, there's a bit of blood come in the water sea, but now it's fine. There's no
Yeah,
blood
how
coming
much
from the
was the
chest.
count water cell drainage?
150.
150 ml. Okay, it's good. So if it is more than 1,500 liters, so we should proceed for a cardiac surgeon, or need to expose the chest to do. So we will now maintain this patient's criteria. Patient is stable at present. How you are feeling after the morphine injection?
She got, yeah, pain is better, but she still got pain in her tummy.
Okay. Can we? Patient is having pain in the tummy also. So we are getting. Can we do ultrasound, fast ultrasound scan for this patient?
Yeah, you can do grab it. Yeah, it's
So
clear.
we will do both together, fast ultrasound abdomen and also e-fast in the chest.
Negative.
Yeah.
Yeah.
So fine. Patient is till now patient is stable with us. So is gynae team arrived?
Not yet.
Okay. So we will auscultate we can get the heart sound of the baby or not. And baby,
Time. That's 8 minutes.
it's fine. Okay.
Good. Okay, Murtaza, how do you think? How do you feel about this one?
I think I made all mess up.
So what went well?
Actually, I didn't follow the whole algorithm method, bathing, circulation, then these things. I forget about the circulation. I started on the bathing. Airway, she was talking, then I went to bathing and I forget the circulation.
Is that went well or went wrong?
Went wrong.
So what went well? What went well? What done well?
I
So
ordered for.
I think you've got a structured approach, but you need just to refine it and polish it a bit.
Polish.
Yeah. We need polishing. So this what we trying to train people on, to have a structured approach, whatever you've got in a resuscitation. Is it a trauma in pregnancy? Is it an elderly trauma? Is a young guy with a trauma? Is it pediatric trauma? Whatever trauma you've got, you have a structured approach you need to do. Okay. So if it is a trauma, MRCEM is an exam to assess registrar, isn't it? Yeah, so you are stepping up to be a senior registrar, what the Royal College called the safe hand. So you still need to escalate, you still need to seek help. So if it is a trauma and pregnancy, the first thing you need to do is to activate your trauma team. Yeah.
Okay.
So yeah, initially you need to activate the trauma team. You need to escalate this to your consultant. Okay. So in FRChem, you are the consultant in the exam, but now you are the senior registrar. So first thing, so you need to activate the trauma team. I would, in this scenario, activate the major hemorrhage protocol. You can do this later on the C, but that's fine if no one gonna score you low if you activate this early with a young lady, pregnant lady, hypotensive. Yeah. And then let the A&E consultant know. Okay. And then as you did, you introduce yourself. You are the team leader and you know who's on the scene can help with you. And then A to E assessment, you need to stick to this. Yeah. A to E assessment. So airway. Yeah. So you started with the airway. You asked her, she's opening her airway, isn't she? Yeah. She told you. So open, the airway is open. And then you asked for C-spine immobilization. Have you done this? Or I missed
Yes, sir.
it? Yeah,
I've done.
you've done it. Yeah. And then straight away you put oxygen on.
Okay.
Straight
I
away.
forget to
Yeah.
put up.
Yeah. You have to put oxygen. If you didn't ask for a monitoring, they will not offer to put the monitoring on.
Yeah.
Yeah, so you have to ask the nurse to put the monitoring on, so you have a clue what's going on. So there is no monitoring for a while. For half the station, there is no monitoring on because you didn't ask for. Yeah.
Yes.
So again, and you go to the trachea, as you said, is it central? Is there any subcutaneous emphysema? And then you go to the breathing. And now when you assess the breathing, you don't have a saturation level.
Yeah,
You
not
didn't ask
connected.
for, yeah. There's no saturation level because you didn't ask for monitoring. Okay. So what's the saturation? Oxygen saturation. Okay, she's in 15 liters. What's the oxygen rate? What's the respiratory rate? Okay. An inspection. Is any blood coming from the back as well of the chest? Okay. When I'm feeling the chest, any deformity, any bruising, yeah, any discrepancy. All this you need to do. Not all. So you've done the auscultation, you've done the percussion. Absolutely fine. You identified she's got a hemothorax. Yeah, well done. And you put a chest drain. What is different when you put in a chest drain in a 32-week pregnant lady?
We have to put it on the fourth intercostal space.
Yes,
So
where did you put
you have
it?
to go high. You went down. You went
I
seventh.
went to the fifth intercostal
Yeah.
space.
Yeah, so this is another trick. You have to put it a little bit up because the gravid uterus pushing the lung
Yes.
upward, isn't it? So there's a risk of liver injury. Very low, but there is a risk. Yeah. Then you've done an intervention, which is a chest drain. What you need to do next?
I have to check how much the blood is coming from the tube. It is working or not.
Give me
I have
one
to examine it.
one word, and I need one word. After every intervention in trauma and resuscitation, what do you need to do?
Again, I need to check that
Reassessment.
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 Always reassessment. Remember this buzzword, reassessment.
Yes. So reassessment, you go from A. Okay.
Mhm.
So is the patient still talking? Yeah, you don't know what happened. You put chest drain, you open her chest, you went with your finger to the lung, you put a chest drain in, there's blood coming out. Is the patient still breathing? Is the patient still talking? Airway is fine. Okay. How's the and as you said, how's the air entry? How's the percussion? How's the oxygen level now? Is it getting better? So reassessment again from A. If you're doing even like you gone to D and the patient is hypoglycemic and you're given some dextrose, you need to do a reassessment, not all only to check the blood sugar, but to start from A again. A, B, C, D. Yeah, so after any intervention, it's very simple. It's very simple, but you need to stick to a structured approach. Okay. And then you've done well, I think. So Fakhro was very generous to offer you the bloods because this meant to say we can't get a blood on, and then you can ask for an IO, okay? And then they will take a blood gas from the IO. He said as well, major hemorrhage protocol is activated. You should do that. Okay, they wouldn't offer this in the exam, so you should say activate major hemorrhage protocol. And what the 30 drops per minute? Is that your practice in your which hospital are you working on?
Actually, at present, I'm out of job.
Okay,
All right.
okay.
Just say bolus. Just say bolus.
Yeah,
Don't
yeah,
say the.
just say
If you don't know, just
bolus
say
or
bolus.
step. Yeah, but it's a bit confusing, 30 drop per minute.
Actually, I was confused
So
what to say.
this you are telling them by saying this word that you are not in practice. So if you
Yeah,
don't know, say bolus.
Okay.
yeah, absolutely. And then yeah, you said about the O negative blood. So when you're assessing the C, what you doing? Tell me, C assessment.
We have to see the blood pressure, circulation is maintaining or
Mhm.
not, and also
Yeah, so external bleeding,
heart rate.
okay, there's no external bleeding. Capillary fill time,
Yeah.
you need to do,
Yeah.
capillary fill time. And then
Mhm.
pulse, blood pressure, abdomen, pelvis, long bones,
Yeah.
where you can, where you can lose a lot of blood. So abdomen, pelvis, long bone. Okay,
Done.
what is different in a pregnant lady? Abdomen, C, circulation. What you need to do?
We need to turn the patient towards the left side.
Why you didn't do that then?
We are waiting for that.
Yeah, so left lateral position.
Yes.
Yeah.
Left, left.
Or you just want ask someone to hold the uterus. Yeah. To
Close
push
it.
the uterus away from the inferior vena cava, IVC. So the blood pressure will get better. Yeah.
Yes.
If you suggested a pelvic binder, that's absolutely fine. Because it's
Okay.
trauma. So say put a pelvic binder, that's fine. Absolutely fine. Even if the pelvis is stable. No one will judge you about this. But I would score for this. Yeah. Until she had a but she will eventually she will go for a trauma scan. Yeah. And then D, what you're doing for D? Yeah, GCS, pupils, BM, and then E, you're doing the whole, have a look,
Any
expose
bleeding,
the
anything,
patient,
any
make sure there's no
bleeding.
other injuries. Yeah, and then rewarm, because the lethal triad in trauma is, one of them is what? Yeah, to be hypothermia. So you have to warm her, and then it's ongoing reassessment. Yeah, A to E assessment. And if you do that, then you will clearly pass any resuscitation station. Mehdi, do you want to add on anything?
Yeah, Johar, I can say honestly, you have a knowledge. Definitely, you have a knowledge, but it is haphazard. You need, as Khalid said, structured approach, and you need some polishing. Which definitely, if you join our course, we will. The aim of our course is to streamline your knowledge, to polish and put it in the proper structure. And like you said a word like vaginal examination, that comes in secondary survey, not in the this. So don't. So these small things will pick up once you do practice with us. Okay, I can say definitely you have a knowledge, you know this stuff, but you need a structured approach and you need bit polishing. That we're happy to do it. Yeah.
Great. Perfect. Yeah, so we can just run through quickly. That's the trauma primer survey. As we said, like A, airway, C, spine, analgesia you can give. Yeah. B, breathing, oxygenate, ventilate. C, circulation, stop bleeding, support circulation. So as you said, IV fluids, and O negative. GCS, pupils, BM for D, and then expose and prevent hypothermia. And this is a bit of detailed A to E assessment. And now what we are doing is we are doing a revision guide on our website, www.emskillsacademy.com. It's a revision guide for you guys, absolutely for free, for MRCEM and FRCEM, which will have a detailed details for every station, how to approach it. It's called Revision Guide, MRCEM and FRCEM. So go there, have a look, have a read, and get benefit from this. As we said, trauma primer survey in pregnancy, the only difference is anticipate difficult airway, because sometimes there's a mucosal edema because of the pregnancy. Give 100% oxygen, 15 liters, non-breathing early. Thoracic injury, you need a higher chest tube, as we said. Don't forget about the left lateral position, and it will be a bonus if you mention CTG to monitor the heart rate for the baby as well. Yeah. So maternal stability is priority. Seek help early. Trauma, obstetric, as you done, you can ask for neonatology as well if she's a bit far in her pregnancy, and ensure fetal monitoring and addressed, and any complication being dealt with promptly. That's fine. So that's what we do in our online courses, guys. So we run a MOOC station, the same as in the exam, for the all kind of stations and domains. One day we take around 20 station, and we make it on small groups, and we split it between senior instructors, consultant, and then instructors changes as well in between groups to get more and more experience. That's our website. It's got the revision guide for you guys, all information about our courses, the barcode if you want to join our Facebook and our Telegram group as well. And again, if you need any question regarding the exam or your career in emergency medicine, just go on our website, book a slot with a senior consultant to have a chat with you and give you a personalized advice. Anyone have any question at this stage?
Sir, if you don't mind, can I ask some question?
Yeah, absolutely.
Yeah, actually, I was thinking to join the face-to-face course on 24th and 25th of May. And also, as I now just make a demo practice, so I am thinking that it's also important to join the course also. But that's why I was in puzzle that if I will join the face-to-face, so it will help as same as course 2 days.
Yeah, of course, face-to-face is always preferable if you can, because you will have the, everything mannequins and exam like feel. But if by some reasons people cannot, then still you have an option of online.
Okay. No, I will come directly to the hospital, your hospital, and I will do the face-to-face. It is okay for that.
Yeah, that's good.
Yeah.
That's good.
Yeah, absolutely.
And
I
also,
think
I was
there's
just thinking that
yeah.
about this course for 2 days, it is obviously it is beneficial, but if I only add the face to face, so it will be also helpful for me.
Yeah, why not?
Okay then. Thank you.
Right. We have George here. George, are you still with us? Do you want to say anything? There is a question, when is it in India? It is just in India, it is just before the exam. I think it's 8 to 10 July. So exam is in July. It's a week before the exam. So it is 8 to 10 July. It's 3 days in India, face to face. It's Hyderabad.
Yeah, Hyderabad. And we've got another question as well from Ashini from Sri Lanka, waiting for OSCE slot. Can you explain your course details? Slots are not predictable, but I would like to be in touch. Okay, yeah, I mean, so what details do you want to do? So we do, as we said, we do the online course. Yeah, it's 2 days, and face-to-face course with again 2 days, and every course every day is 20 station. So you've got the cost for the 2 days course. So for the cost, it's all on our website. So if you go emskillsacademy.com, www.emskillsacademy.com, you can go to our website and then all the course details. But in summary, it's 2 days and every day is 20 stations. So you got 40 different stations for the all exam domains, covering all the 7 domains. Okay. To be honest, like we can do a bonus for the people who participated today if Mahdi is happy with that. So if someone is want to join our courses and have problem with the fees, so get in touch on our WhatsApp. This is a WhatsApp number here, and then we'll give you a discount as well. We can give you
There's one private question sent to me. They're asking, I have not got the slot. If I join your course, and can I join your next course on the same fees?
yeah, absolutely.
Yeah, I think if you have not got the slot, you won't book with us this time. You can you can basically in the same fees do the 2 courses. There will be course before the next exam. You can have that in the same fees.
Yeah.
Face to
So
face,
if
will you?
you
Yeah.
Well, can I just explain, Mahdi? So if you want to book our course and you haven't got, you can book the course. If you haven't got a slot, you have 2 options. We do either a full refund for you, or if you can keep the fees for the next upcoming course. We are very, very flexible. Yeah. And if anyone have any problem with paying the fees, so just get in touch with us and we can make a discount for you guys.
Face to face, will you teach us or should I come fully prepared and you just test us? So basically it is both. We teach you, we polish you, we organize your skills, but because the face-to-face course is just before a week, so we expect you to start preparation from now. We are putting inputs and the guidance in our group as well, so that by the time you have at least the basic knowledge, the 2 days will polish you, organize you, and train you, and definitely teach you as well. But then you will have very less time until the exam. So if you start preparing now, then chances of pass is very, very high.
Yeah, I wouldn't just rely on the course, so it need preparation, guys. It's, as Mahdi said, you're doing this course to polish and enhance your skills, and give you a bit of adjustment to your approach, okay? And draw some structure approach for you as we did with Mortaza now, how to deal with these stations. Then it will be clear path. But if you are not preparing at all, and you only rely on the 2 days course, I wouldn't recommend that at all. Absolutely. If people is not
Yeah.
preparing and just want to attend 2 days course to pass the exam, no, that's it's not working like this. Okay.
There's a question about tranexamic acid.
Yeah,
What
absolutely.
what about tranexamic acid? If trauma patient comes within 3 hours of injury, will you give tranexamic acid? Yes.
Yes.
And maintenance dose after 8 hours? Yes. So what about the pregnant lady? Shall we give
We still
or
can
not?
give, yeah,
Yeah.
absolutely.
Yeah. So only, we give in all trauma, we give tranexamic acid.
Yeah.
Any further questions?
Great. I think that's it. And is Georgina still here? George, is she still here? Don't you say anything before we? No. Okay, fine. So thanks so much, everyone, for joining us today. I hope this session was a bit of help for you preparing for your exam. As I said, if you need any help with anything, just get in touch with us. So we've got our website, our Facebook, our Telegram, our WhatsApp, all for you anytime. If you need any question, need any help with anything, just pop up a question for us, and we'll be more than happy to help and assist you. Okay? And
Yeah, if you have
hopefully
any
you all
further
pass your
questions,
exam
just put in
clearly.
the Telegram group. You are all in Telegram group. Just put questions there if you have any doubt or question.
Great. Okay, guys, and all the best for your exams, and hopefully you all pass with a very clear, easy pass. And we'll see you.
Thank you very much, sir.
Thank you. Bye-bye.
Thank you. Thank you, everyone. Bye.